Hello everyone, this is Jill Rourke from the Centers for Disease Control and Prevention, and I'm glad that you were all able to join us today. I do want to go ahead and get started. We have a lot of great information. We're going to be having two presenters today. We're going to have Dr. Lauri Markowitz, who is the lead for the HPV work group here at CDC, and also the CDC lead for the ACIP's HPV vaccination work group. And Lauri is going to go over the changes in the recommendation after the most recent ACIP meeting. Next, we're going to have Tom Shimabukuro, who is in our Immunization Safety Office, and he will be giving us an update on HPV-9 vaccine safety. So I'm going to go next to our webinar logistics and just remind everyone all of your lines are muted, and because of that we're going to have to do our Q&A session a little bit differently than we have in the past. We are recording this webinar and everyone is notified that is recording. The presentation will also be available online later, and that's why we're recording this today, and we will send that out once it's available. Also, as I said before, since everyone is in a listen-only mode, you're going to need to type your question into the question panel on GoToWebinar in that side panel. And then when it's time for questions, we'll read the selected question out loud for our presenters to answer. And Ian Brannon, who is on the Adolescent Immunization Communications team, will be moderating the questions for us. We are going to hold all questions until the end after both presenters have presented. And now I'm going to go ahead and turn it over to Dr. Markowitz.
Okay, good morning. It's Lauri Markowitz, and today, as was just mentioned, I will be giving an update on HPV vaccination recommendations in the United States. Okay, it looks like I don't have control to advance, so please advance the slide. Okay, this is an outline of my talk. I will be giving an overview of HPV vaccines available in the U.S., HPV-associated cancers due to different HPV types. I'll review data from the 9-valent HPV vaccine trials, and then summarize the updated recommendations of ACIP. Next slide. All available prophylactic HPV vaccines are virus-like particle vaccines, and these vaccines are made from the L1 major capsid protein of the virus, which is expressed through recombinant technology, and the L1 proteins self-assemble into virus-like particles, which are non-infectious. Until recently, there were two available HPV vaccines, the bivalent vaccine, also called Cervarix, which is directed against HPV 16 and 18, and the quadrivalent vaccine called Gardasil, directed against types 6 and 11, as well as 16 and 18. The HPV 16 and 18 are oncogenic HPV types, which cause cancers, and HPV 6 and 11 cause genital warts. As I mentioned, both of these vaccines are similar in that they're both VLP vaccines. In addition to the differences between the vaccines through the different HPV types, the vaccines also differ in their adjuvants. The recently licensed 9-valent vaccine, also called Gardasil 9, is directed against the same 4 types as in the quadrivalent vaccine 611, 16, 18, and 5 additional cancer-causing types shown in red on this slide. The quadrivalent and the 9-valent vaccine are produced by the same manufacturer, and they have the same adjuvant. As I just presented, all HPV vaccine types target oncogenic or high-risk types, HPV 16 and 18. These 2 types are responsible for most cervical cancers and the majority of other HPV-associated cancers. This graph shows the percentage of cervical cancers attributed to the high-risk types worldwide, and you can see that HPV 16 and 18 account for 60% and 10% respectively of the cervical cancers that were HPV positive. The other high-risk types each accounted for a small percentage of cervical cancers. And while there's some variation by geographic location, 16 and 18 account for the vast majority of HPV-positive cervical cancers worldwide. In addition to cervical cancer, HPV causes cancers at other sites, and this slide shows data from the U.S., with the estimated number of cancer cases at anatomical sites where they have been attributed to HPV. For males on the left and for females on the right, and the purple portion of the bars show the cancer cases at these sites that are attributable to HPV. And you can see that most but not all of the cancers at these sites are attributable to HPV, and this does vary somewhat by the cancer. The most common HPV-associated cancer for females is cervical cancer, and the most common HPV-associated cancer for males is cancer of the oral pharynx. Now, these data are from a study conducted to examine the specific HPV types in cervical as well as other HPV-associated cancers in the U.S. The first column are the cancers associated with HPV, and the second column are the percent of cancers at these sites in which HPV has been detected. The third column shows the percent attributable to HPV-16 and 18, and the last column, the percent attributable to the 5 additional types in the 9-valent vaccine. You can see that the majority of cancers at all sites are attributable to HPV-16 and 18, ranging from 48% to 80%. The percent attributable to the 5 additional types in the 9-valent vaccine is lower, ranging from 4% for oral pharyngeal cancers in males to 18% of vaginal cancers. Using data that I just showed from the previous study, this slide shows the estimated number of cancers at these anatomic sites attributable to HPV-16 and to the 5 additional types in the U.S. using data from 2006 to 2010. Again, as noted in the previous slide, the majority of all cancers that are attributable to HPV are attributable to 16 and 18. The blue bars show the cancers that are attributable to the 5 additional types in the 9-valent vaccine. And you can see here that for females, the largest number of cases to the 5 additional types are for cervical cancers. So in summary, just to review what I went over in the United States, there's approximately 33,000 HPV-associated cancers per year. About 64% of these are attributable to 16 and 18. 16 and 18 account for about 66% of cervical cancers, and for the other cancers, the percent ranges from 48% to 80%. About 10% of HPV-associated cancers are attributable to the 5 additional types in the 9-valent vaccine, 15% of cervical cancers, and for the other cancers, the range is 4 to 18%. Due to the differences in the HPV types attributable to the cancers at different sites, there are differences by sex. The 5 additional types count for about 14% of HPV-associated cancers in females, only 4% of HPV-associated cancers in males. And for cervical precancer lesions that are detected through cervical cancer screening, about 50% are attributable to HPV-16 and 18, and about 25% to the 5 additional types in the 9-valent vaccine. Now I'd like to move on and talk about data from the 9-valent HPV vaccine clinical trials. The 9-valent vaccine was licensed by FDA in December 2014. The trials conducted for licensure included a pivotal efficacy trial, immunogenicity and immunobridging trials, and concomitant use trials. The 9-valent efficacy trial included over 14,000 women aged 16 to 26 years, and they were randomized to receive either the 9-valent vaccine or the quadrivalent vaccine. There was no unvaccinated group for comparison in this study. The objectives were to demonstrate efficacy for HPV 31, 33, 45, 52, and 58 related endpoints, and to demonstrate non-inferior immunogenicity for the HPV types 6, 11, 16, and 18. Since both vaccines target the 4 types in the quadrivalent vaccine, it was not possible to evaluate efficacy against those 4 types. The 9-valent HPV vaccine efficacy trials show high efficacy against the 5 additional types in the 9-valent vaccine in the per-protocol population. You can see here there was high efficacy against a combined endpoint of high-grade cervical, vulvar, and vaginal lesions due to the 5 additional types, 96.7%. There were a variety of other endpoints evaluated, and I am showing here the efficacy against 6-month persistent infection, which was 96%. As noted on this slide, there were few high-grade outcomes due to HPV 6, 11, 16, and 18 types against which both vaccines protect. There was only 1 case in the 9-valent group and 3 in the quadrivalent group. And because of this, efficacy was inferred from immunogenicity. Antibody titers were evaluated for these types, and the non-inferior immunogenicity was demonstrated for all 4 types. There was over 99% seroconversion, and geometric mean titers were non-inferior between the 2 groups, non-inferior in the quadrivalent group compared to in the 9-valent group compared to the quadrivalent group. This slide shows results from the 9-valent vaccine adult-to-adolescent immunobridging study. This is one of the studies that allowed licensure in the younger age group. And this study compared the geometric mean titers in 9 to 15-year-olds, shown here in green, to females 16 to 26. This was the age group that was in the efficacy trial, and that's shown in purple on this slide. Not only was non-inferior criterion met for all 9 HPV vaccine types, but the geometric mean titers were higher in the younger age group. This is a similar finding to what was seen for the quadrivalent and the bivalent vaccines previously, that the antibody response to vaccination is higher in the younger adolescents. This slide summarizes some of the data I just presented, as well as some other data from the trials. Efficacy, there was about 97% protection against the 5 additional types in the 9-valent vaccine, and similar protection against the 4 types shared by both the quadrivalent and the 9-valent vaccine. There was non-inferior immunogenicity for HPV 6, 11, 16, 18 compared with the quadrivalent vaccine, and for all 9 types in adolescent females and males compared to adult females, and in adult males compared to adult females. The concomitant use studies show that there was no impact on immunogenicity or safety when the 9-valent vaccine was administered with Menactra or the Adacel. As always, safety is evaluated and reviewed in the pre-licensure trials. The trials included over 15,000 9-valent vaccine recipients, and 9-valent vaccine was generally well tolerated, and the safety profile was similar to the quadrivalent vaccine. There were more injection site reactions with the 9-valent vaccine, specifically swelling and erythema. And these reactions increased with the number of doses administered, again, as was seen in the quadrivalent trials. And in the concomitant use studies, there was no difference in the safety profile when co-administered with other vaccines that were evaluated. Now I'll discuss the updated ACIP recommendations. This slide shows ACIP's previously published recommendations. Since 2011, the recommendations have been for routine vaccination of boys and girls at age 11 or 12, and the vaccination series can be started at age 9 years. Vaccination is also recommended through age 26 for females and through 21 for males not previously vaccinated. Vaccination is recommended for immunocompromised persons, including persons with HIV infection, and for men who have sex with men through age 26. A 3-dose schedule is recommended, and previously the vaccines that were licensed and recommended were bivalent or quadrivalent vaccine for females and quadrivalent vaccine for males. Before I review the updated recommendations, I want to mention the licensed age groups for the 3 available vaccines in the U.S. The bivalent vaccine is licensed for females 9 to 25 years. The quadrivalent vaccine is licensed for females and males 9 to 26 years. And the 9-valent vaccine is licensed for females 9 to 26 years and males 9 to 15 years. At the time of the first application to FDA, the 9-valent vaccine trials in males 16 to 26 years had not been completed. Immunogenicity data for 16 to 26-year-olds are now available and were reviewed by ACIP last year, and these data have been submitted to FDA. When ACIP deliberated on 9-valent vaccine, the committee recommended use of 9-valent vaccine in the currently recommended age groups, including for males. The 16 to 26-year-old recommendation for males then is currently an off-label recommendation. So these are the updated recommendations. Again, the first 3 bullets are exactly the same. The routine recommendation is for vaccination at age 11 or 12 years. Vaccination is recommended through age 26 for females and through age 21 for males not previously vaccinated. And vaccination is recommended for men who have sex with men and immunocompromised men, including those with HIV infection, through age 26. Vaccination of females is recommended with the bivalent, the quadrivalent vaccine, or the 9-valent vaccine. And vaccination of males is recommended with the quadrivalent vaccine or the 9-valent vaccine. The updated recommendations include some wording on the differences between the vaccine, including the fact that the bivalent, the quadrivalent, and the 9-valent all protect against 16 and 18, types that cause about 66% of cervical cancers and the majority of other HPV attributable cancers in the United States. The 9-valent vaccine targets 5 additional cancer-causing types, which account for about 15% of cervical cancers. And quadrivalent and 9-valent vaccine also protect against 6 and 11 types that cause genital warts. For administration, there are minor wording changes, but the recommendation is similar to what it was before. Interchangeability first. The wording here for interchangeability states that if vaccination providers do not know or do not have available the HPV vaccine product previously administered or in settings transitioning to 9-valent vaccine, for protection against HPV 16 and 18, any vaccine product may be used to continue or complete the series for females, and quadrivalent or 9-valent vaccine may be used to continue or complete the series for males. Now for administration. For administration, there are minor wording changes, but the recommendation is similar to what it was in our previous recommendations. The vaccines are each administered in a 3-dose schedule, and the second dose is administered at least 1 to 2 months after the first dose, and the third dose at least 6 months after the first dose. And if the vaccine schedule is interrupted, the vaccination series does not need to be restarted. There are no changes in the recommendation regarding vaccination during pregnancy. Vaccine is not recommended for pregnant women, and if a woman is found to be pregnant after initiating the series, the remainder of the doses should be delayed until after completion of pregnancy, but no intervention is needed and no pregnancy testing is needed before vaccination. A new pregnancy registry has been established for 9-valent vaccine, and of note, the vaccine pregnancy registries have been closed for the quadrivalent vaccine and the bivalent vaccine with concurrence from FDA. One question that has been raised is about 9-valent vaccine for persons who have completed a HPV vaccination series. Of note, the manufacturer did not seek an indication for 9-valent vaccination for persons who previously completed an HPV vaccination series. However, a study of 9-valent vaccine in prior quadrivalent vaccinees was conducted mainly to evaluate safety. Due to time limitations, there was an abbreviated ACIP meeting in February. This was not discussed and will be presented to ACIP at a subsequent meeting. So in summary, the 9-valent HPV vaccine was licensed by FDA in December 2014 and was recommended by ACIP in February 2015. It is one of 3 vaccines that can be used for routine vaccination of females and one of 2 for males. It targets 5 additional high-risk types. Overall, 14% of HPV-associated cancers in females and 4% in males are attributable to these types, and 15% of cervical cancers. There are a variety of next steps, but I want to mention that the 9-valent vaccine has been available from the manufacturer starting in February 2015. CDC has awarded a contract for the 9-valent vaccine, and of course efforts are needed to continue to increase HPV vaccination coverage in the U.S. I want to end with this slide, which I think is shows a graph that is similar to many of you. It shows the national estimated vaccination coverage among adolescents 13 to 17 in the U.S. In the red line is coverage with at least one dose of HPV vaccine, showing increases initially but then leveling off in recent years, reaching 57% in 2013. 3-dose coverage, shown in orange, was 38% in 2013. And in blue are the 1- and 3-dose male coverage estimates. The increase in coverage in males started after vaccine was licensed in males in 2009 and further increased after the routine recommendation for males in 2011. In 2013, at least 1- and 3-dose coverage was 35% and 14% in males. And further efforts are ongoing to increase HPV vaccine coverage in the U.S. for both females and males. There are a variety of resources I want to remind everyone about. Of course, the ACIP website includes slides, minutes, and recommendations. And there are a variety of resources for providers and patients at CDC websites listed on this slide. Thank you.
Hi, good morning. I'm Tom Shimabukuro. I'm the Deputy Director of the Immunization Safety Office at CDC. And today I'm going to present an update of human papillomavirus vaccine safety monitoring and evaluation. Next slide. Next slide, please. In this presentation, I'll provide an update of HPV post-licensure vaccine safety monitoring and publications, which are predominantly studies of quadrivalent HPV vaccine. I'll describe ongoing HPV vaccine safety-related activities currently being conducted at CDC, and then outline plans for vaccine safety monitoring for the recently licensed 9-valent HPV vaccine. Next slide. This slide summarizes CDC's vaccine safety monitoring infrastructure and shows the 3 main components. The Vaccine Adverse Event Reporting System, which is our national spontaneous reporting system that detects potential vaccine safety problems. The Vaccine Safety Data Link, which is a consortium of large link databases used for active surveillance and research. And the Clinical Immunization Safety Assessment Project, a consortium of vaccine safety experts that consults on complex vaccine safety cases and conducts vaccine safety research. There have been a number of publications addressing the safety of HPV vaccine that we wanted to highlight. With regards to general safety, the post-licensure safety profile of quadrivalent HPV vaccine was first described in JAMA in 2009 when results from the first 2.5 years of VAERS safety surveillance were published. Close monitoring of U.S. VAERS reports found that the proportion of reporting for venous thromboembolism, or VTE, and syncope, or fainting, was higher than expected. No other safety signals were identified. Updated VAERS reviews have also been published as part of the 2013 and 2014 MMWR reports on HPV coverage among adolescent girls and post-licensure safety monitoring in the United States. In both reports, it was found that reporting to VAERS was consistent with pre-licensure data and no new safety concerns had been identified. Another study that was conducted was through CDC's Vaccine Safety Data Link, in which near real-time monitoring was performed looking at 8 pre-specified conditions as listed on this slide. No statistically significant associations were found. However, there was a non-significant elevated risk for venous thromboembolism in females 9 to 17 years. Lastly, as part of the manufacturer's quadrivalent HPV vaccine post-marketing commitment with FDA, a general safety assessment was conducted that included approximately 190,000 females who received quadrivalent HPV vaccine in 2 large U.S. health plans. Using a self-controlled risk interval design, the study found that quadrivalent HPV vaccine was associated with syncope on the same day of vaccination and skin infections in the 2 weeks after vaccination. A review of skin infection diagnoses suggested that some of these cases may have been local injection site reactions, although the medical records contain insufficient detail to exclude acute infections. Next slide. Because of the suggestions and concerns of increased risk of specific health conditions, we wanted to highlight recent publications on VTE, autoimmune conditions, and neurologic disease. On this slide, I describe post-licensure safety work that has been conducted surrounding VTE. Addressing the VTE findings from both the previously described VAERS and VSD studies, there have been 2 large population-based studies that have been published using national registry data from Denmark and Sweden, in which both studies found no association between VTE and HPV-4 and quadrivalent HPV vaccine. In addition, while not published, the Vaccine Safety Data Link has recently completed a study evaluating the risk of VTE in vaccinated persons aged 9 to 26 years, which found no increased risk of VTE following quadrivalent HPV vaccine. Concerns have been identified with both autoimmune and neurologic disease following quadrivalent HPV vaccine. There have been 4 large epidemiologic studies in which no evidence for causal associations have been observed. These studies were conducted in the United States, Scandinavia, and France. And I'll pause briefly to let you digest some of the material on this slide. Next slide, please. Finally, we wanted to also remind you that of the Institute of Medicine's report published in 2011 titled Adverse Effects of Vaccines, Evidence of Causality. This report was a review of published literature, and the committee concluded that syncope can be associated with any injected vaccine, including HPV vaccines. And the report also concluded that anaphylaxis can be causally related to HPV vaccines, but HPV is only one of many vaccines for which a causal relationship to anaphylaxis exists. We want to provide an update on HPV vaccine safety-related activities currently being conducted within CDC's Immunization Safety Office. Within VAERS, there is ongoing monitoring of U.S. reports of both types of HPV vaccines. Clinical reviews of deaths and other pre-specified adverse event outcomes as needed, and data mining is conducted to identify signals within the data by our FDA colleagues. CISA is conducting an intervention clinical trial to assess the effectiveness of drinking water before vaccination to prevent symptoms associated with syncope. The following studies are currently being conducted within the Vaccine Safety Data Link. Addressing HPV vaccine safety in populations, there is a safety study among males currently being conducted, as well as an inadvertent HPV vaccination study among pregnant women. These are women who inadvertently received HPV vaccine during pregnancy. And just to remind you, the vaccine is not recommended. Neither vaccines are recommended during pregnancy. The Vaccine Safety Data Link is also addressing safety concerns that have been identified from case reports and/or media, and these include evaluating the risk of autoimmune disease following quadrivalent HPV vaccine, premature ovarian insufficiency following quadrivalent HPV vaccine, and mortality following quadrivalent HPV vaccine and other adolescent vaccines. So moving on to the recently licensed 9-valent HPV vaccine. The 9-valent HPV vaccine was licensed in December 2014, as Dr. Markowitz indicated in her presentation. And on this slide is a brief summary of the safety profile as described in FDA's regulatory action documentation. Among 6 pre-licensure studies, 9-valent HPV vaccine was found to be generally well tolerated. The adverse event profile was similar to that of the quadrivalent vaccine. However, there was more injection site swelling and erythema in the 9-valent HPV vaccine group. Among those inadvertent pregnancies during the preclinical studies, the proportion of adverse outcomes observed were consistent with those observed in the general population. A sub-analysis was conducted of the identified pregnancies within 30 days that resulted in a spontaneous abortion. And these were more frequent than those who received quadrivalent HPV vaccine. However, the spontaneous abortions observed were within what is expected for early loss of pregnancy. At CDC, the following safety work will be conducted for 9-valent HPV vaccine. In VAERS, reports will be monitored along with clinical reviews, and FDA data mining will also be conducted to identify safety signals. In the Vaccine Safety Data Link, a rapid cycle analysis will be conducted. And because the label indicates a possible increase of spontaneous abortion following 9-valent HPV vaccine compared to 4-valent HPV vaccine, VSD plans on conducting an evaluation of this issue. 9-valent HPV vaccine post-marketing commitments to be conducted by Merck include the following. Completion of 2 10-year study extensions evaluating long-term safety, immunogenicity, and effectiveness. One study will be conducted among males and females 9 to 15 years of age, and the other will be conducted among females 16 to 26 years of age. There will be an observational study to further characterize the safety profile in 10,000 persons, and a pregnancy registry will be established to prospectively collect data from spontaneous reports of inadvertent vaccination. The pharmacovigilance plan for FDA Sentinel initiative includes a general safety study and a pregnancy outcome study. So in conclusion, quadrivalent HPV vaccine has a good safety profile as demonstrated by VAERS and Vaccine Safety Data Link safety monitoring data, and published in preliminary data from many sources. Safety monitoring and evaluation will continue for all HPV vaccines. Thank you. This concludes my presentation.
Great. Thank you very much to both of our speakers. And now we're going to go ahead and open it up for questions. And Ian is on. And Ian, if you would go ahead and ask the first question. Oh, wait,
okay, so
on.
the first question we have is,
Ian, I'm sorry. I just realized we were supposed to go to our polling questions. I apologize. Sorry, everyone. So before we ask questions, just for the slides that we've just gone through, if we're going to go ahead and do our first polling question, which is, how helpful was the information presented during the webinar? And we should have a poll should be popping up now. Go ahead and answer that. So please select from extremely helpful to not helpful at all. Hopefully it was helpful. Okay, we'll give folks a couple more minutes to answer this. Okay, let's go to the second question to help us get feedback about this, the usefulness of our webinar. All right, our second question is, have we moved to our second question now? All right, great. So we've got our answers, poll results, extremely likely to use the information posted. Great. Wonderful. All right, so now we will go to our questions that have been coming in from the presenters, from the participants. So presenters will let you know which question this is, who this is for. Okay, Ian, you can go ahead.
Sure. Okay, so this question is for Lauri. Can you offer an opinion or guidance with reference to healthcare professionals recommending the 9-valent vaccine for males and females in the recommended age groups who were previously vaccinated with the bivalent or quadrivalent vaccine?
Well, this is a very common question we've been getting, but as I mentioned, the ACIP has not deliberated on this issue yet. So we do not have any official guidance. We have done some review of the data, and we have done some modeling to show what the cost effectiveness of revaccination would be. But I do want to stress that the vast majority of all HPV-associated disease for both males and females, but particularly for males, is due to 16-18, the types that are covered in the quadrivalent vaccine. But we do anticipate that ACIP will be reviewing these data in the coming ACIP meetings.
Okay. So the second question we have is, if they started on the 4-valent vaccine, can they finish with the 9-valent vaccine?
Yeah, and I did have a slide which reviewed this, that the recommendations do state that the 9-valent vaccine can be used to complete a series that was started with the quadrivalent vaccine. That is in the policy note, which was published at the end of March.
So we have another question with regard to the recommendation for males ages 16 and older. They're wondering if it's recommended for this age group.
Yeah, as I mentioned also, so when the studies were, the pre-licensure studies that were done and initially submitted with the application to FDA only included the immunobridging studies in males 9 to 15. The studies in females included a variety of studies, including the efficacy study that was done in females 16 to 26. So FDA licensed the vaccine for females 9 to 26, but for males 9 to 15. The studies in males 16 to 26 have now been completed. Those data have been reviewed by ACIP and have now been submitted to FDA. When ACIP deliberated on the recommendations for the 9-valent vaccine, they did recommend it through the age groups that are currently recommended for vaccination. So the recommendation is currently an off-label recommendation for males 16 to 26, but as I mentioned, those data have been submitted to FDA. So at the present time, they're off-label, but the recommendation by ACIP is through the currently recommended ages for males, which is routine at 11 to 12, and through age 21 for those not previously vaccinated, and through age 26 for men who have sex with men and immunocompromised men.
Okay, this question is for Tom. They're asking, when will the Gardasil mini sentinel data regarding VTE be published?
I don't have an answer to that. I would have to check with our colleagues at FDA and get back to you on that.
Okay. This person has a question for Lauri. Overall, what % of HPV disease would the 9-valent vaccine cover for females versus males?
So I don't know if we want to go back to one of my slides that can review this, but I can just review it. It is on slide. It is on one of the slides, but basically, based on studies in the U.S., I don't know if my slide numbers I think are different than yours, but it says summary attribution of 16-18. But basically, for females, about 14% of all HPV-associated cancers are due to the 5 additional types, but for males, it's only 4%. And the reason why it's different is because the cancers of the different sites are attributable to different proportion of the types. So again, yes, thank you for bringing that slide up. So you can see here on the bullet, we say 10% of cancers overall attributable to the 5 additional types. 15% of cervical cancers are attributable to the 5 additional types. But there are differences by sex, so 14% of the HPV-associated cancers in females and only 4% of the HPV-associated cancers in males are attributable to these additional 5 types.
Okay, this question is with regard to the VFC program, and they're wondering, will the HPV-9 vaccine replace all HPV-4 vaccines?
Well, currently there is a contract for the 9-valent vaccine. I think this is a question more in terms of the company's plans, perhaps, but right now both the quadrivalent and the 9-valent vaccines are available from the manufacturer. We anticipate there will be eventually only the 9-valent vaccine available, but the transition will not be immediate, as it was maybe for the transition from Prevnar 7 to Prevnar 13. I think it probably is anticipated it would take about a year or slightly longer for that transition to take place. I can't comment on vaccine availability through VFC. I don't know if there's anyone else on the call that can comment on that.
Shannon, if people need to know about vaccine availability through VFC, who can they contact?
Hi, yes, they should contact their state immunization program and talk to them about the availability of the 9-valent vaccine through the VFC program. It is, we do have a contract for that, so it is available through the VFC program, but they'll need to talk with their state immunization program to find out when they're available to start ordering it and how much is available.
Okay. This is a question, I'm not sure if we answered this exact question earlier, but they're asking if started on HPV-4, then switched to HPV-9, will they need to have 3 doses of 9-valent?
Right now, there is no recommendation for 9-valent vaccination for individuals who have completed an HPV vaccination series. So we have no recommendation for that. So if someone has started, they can complete the series with the 9-valent vaccine. There are no data right now on whether or not that will provide protection against the additional 5 types. But we do not have a recommendation right now for additional vaccination with the 9-valent vaccine if you've already completed a vaccination series with any vaccine.
Great. So this question, there's a question with regard to vaccine safety. This person is wondering if there was any evidence of increased episodes of syncope in the 9-valent HPV vaccine study group.
This is Tom. This is Lauri, go ahead. I'm actually not familiar if there was any in the clinical trials for 9-valent.
There have been very few syncopal cases in the trials. Part of the reason for that is that they during trials they make sure people are sitting down or laying down, but there have been very few cases, and there were no differences in the trial to my knowledge.
So I'll just add that the IOM concluded that syncope is causally related to receipt of any vaccine, any injectable vaccine. It's also related to any type of medical procedure that involves a needle stick, like a blood draw or donating blood. So it's been observed following vaccines, particularly in adolescents. But there are recommendations about waiting periods, and it's important to observe those waiting periods to prevent any complications from a syncopal episode.
Okay. Okay, this person is wondering if the interval of vaccination for the quadrivalent vaccine is the same as the interval for vaccination of the 9-valent vaccine.
Yes, the trials that were done for the quadrivalent were 0, 2, and 6 months, and those were the same intervals that were used for the 9-valent vaccine trials, 0, 2, and 6 months.
We have another question about if vaccination should be given to males ages, if vaccination can be given to males ages 22 through 26 regardless of sexual orientation.
Yes, the vaccine is licensed through, the quadrivalent vaccine, let me say, was licensed in males through age 26, and the same recommendation is currently for the 9-valent vaccine, that it's recommended through age 21. It can be given through age 26, but it's specifically recommended for men who have sex with men through age 26 and immunocompromised men.
Okay. I'm not sure if someone on this panel will be able to speak to this question, but they're wondering if there's a cost comparison between the quadrivalent and 9-valent HPV vaccine.
Yes, you mean the private sector cost or the public sector cost, or a cost effectiveness analysis?
They don't specify. They don't specify. Maybe if you could just provide some cost effectiveness data that you found.
Yeah, I mean, as is required, we do cost effectiveness analyses at the time ACIP deliberates on any new vaccine, and there was some cost effectiveness modeling done for this, and 3 different models have looked at this question in terms of the cost effectiveness of the 9-valent vaccine compared to the quadrivalent vaccine, and that analysis was done because I think, as most people know, the vast majority of vaccine being used in this country is quadrivalent vaccine, and all those models showed that under the base case, as well as in sensitivity analyses looking at a variety of assumptions, that the 9-valent vaccine, assuming it didn't cost any more than about $13 more than the quadrivalent vaccine, that the 9-valent vaccine would be cost savings compared to the quadrivalent vaccine in a program of both male and female vaccination. So I hope that answers the question.
Great. That's awesome.
Before we go to the next question, actually, can we have someone answer about the cost of 9-valent vaccine? I think we have the public sector cost, don't we, Shannon?
Yeah, so on the public sector, the 9-valent vaccine costs about $134 per dose. In the private sector, it's around $163 per dose, but that may vary in the private sector.
Great, thanks, Shannon.
Okay, we have another question. A participant, their daughter is supposed to get the 3rd dose of the quadrivalent vaccine, and they're wondering if they need to wait for the 9-valent vaccine to become available to get that dose instead.
Well, our current recommendations is to be vaccinated with whatever vaccine is available in the provider's office. We don't know when these, the 9-valent will be available in providers' offices, so that is our current recommendation to be vaccinated with whatever vaccine is currently available. As I mentioned, the majority of all HPV-associated disease in males and females is due to HPV-16 and 18, which is for which all vaccines provide protection.
And we have a follow-up question to the question about cost. This person is wondering if the $13 cost difference is per dose or for the overall series.
Yeah, I'm sorry. Yes, that was per dose. The modeling was based on a per dose. In the base case, it looked at the per dose cost of $13 more for the 9-valent compared to the quadrivalent. It did use a range of cost assumptions, and it still remained cost savings and certainly cost effective if the price increased beyond that. But that was the base case used, additional $13 per dose. Those slides are on the ACIP website, but the publication is not yet available.
We still have time for a couple more questions if folks still want to send more of those in.
Okay, we have a question for further clarification on the recommendation for males aged 22 through 26. Wondering if 9-valent vaccine can be given if it's not a man who has sex with men or immunocompromised.
Yeah, I mean, it can be given in that age group. That is the current recommendation for the quadrivalent vaccine. As I mentioned, ACIP made the same recommendation for the 9-valent vaccine, that it's recommended through age 21, but it can be given through age 26.
One moment, I'm just trying to scan through these questions. This person is wondering if we will see a revised Gardasil VIS, and if so, when?
Shannon, are you able to address that? I think there are revised VIS that are being worked on for all the vaccines. That's my understanding.
Yes, and I know that they have developed a VIS for the 9-valent vaccine, but I'm not exactly sure what day, when it will become available, but I know that has been developed.
This is Jill, and actually I was just looking to see, I think it was supposed to be sometime this week or next week, so it should be very shortly that is up, and we will send out an alert on the Preteen Vax News newsletter to let folks know when that is available.
We have a question. Somebody's wondering if ACIP will be evaluating data on a 2-dose schedule at a future ACIP meeting.
Yes, ACIP has reviewed data on 2-dose schedules twice in the past year, or has had presentations on 2-dose schedules. There are some data available for the bivalent and quadrivalent. There's currently a large trial going on of the 9-valent vaccine looking at 2-dose schedules. That is a trial looking at both 0-6 and 0-12-month intervals between the first and second doses. And we anticipate that those data should be available at the end of this year or early next year, and ACIP will be reviewing those data as soon as they're available.
Let me see.
All right, we're just going to take a look for any final questions right now.
This person is wondering that it says you noted that ACIP recommended either the quadrivalent or HPV-9. They're wondering why not recommend only HPV-9?
Well,
Lauri,
eventually...
Go ahead, Lauri. I was just going to say that's a question for you.
Yeah. Eventually, there will be a complete transition to HPV-9. Particularly for males, there is really very little advantage to the HPV-9 over the quadrivalent vaccine. But during this transition period, the recommendation was for any vaccine, and ACIP did not express a preference for one vaccine over the other.
I think that about covers the questions we received.
Excellent, great. Well, thank you everyone so very much for participating, and I would like to thank both of our presenters, Lauri and Tom. We really appreciate you coming on and providing this information. This is the first in a series of webinars that we'll be having titled Preteen Vaccine, and we will be sending out notices of those webinars the same way that you received the one about this one. And we will also be posting this webinar in the next couple of weeks with a link to the YouTube site, CDC's YouTube channel, CDC Streaming Health. Will be hosting the video. There'll be a web link from the cdc.gov/HPV site, as well as cdc.gov/vaccines/teens, and we will send it out in the newsletter. And everyone that registered for the webinar will also get a note about it being posted as well. We thank you very much, and if you have any additional questions, please do not hesitate to email us at preteenvaccines@cdc.gov. Thank you, everyone.